Good morning.
Good morning.
How are you?
All right, and yourself?
I'm good. Every time I look at the intro, I'm like, okay, I'm gonna have to catch a picture, or I'm gonna have to take a picture of you now holding the church announcement stand. How was your week?
It was okay. How was yours?
I don't even know. it
Uh-oh.
was okay. For the most part, it was fine. Yeah, it was okay. I made it. Lord, I
There you
made it.
go.
But I capped off. I'm so tired. And I felt like I was looking in the mirror this morning. I was like, oh my God, my eyes was puffy. I was crying and crying and crying. I went to um see, first of all, I'll be acting like I don't have a whole job on Saturday morning sometimes that I have to be up early in the morning for. Sometimes I just act like I don't have a whole thing, a whole other life. But I went to the Kirk Franklin the reunion tour last night.
Oh, okay.
I didn't get home till after midnight.
Oh,
But it was I know. Like literally, I was gone all day. I didn't come back home. I left the office and went to the concert and was just gone all day.
wow.
I know. I know. I'm paying for it now. I still have a lot of stuff to do, but it is what it is. I have a whole wedding to go to today. I got work.
Wow.
I got a whole bunch of stuff going on. I swear sometimes I have to remind myself, girl, you are not 20. Sit down. But if you get a chance to go, that concert is the bomb. Oh my God, it was so good. And it was so good. And I don't know, Fred Hammond's story, he was with him, but he had like a brace on his arm. I think they said he had a hip replacement or something.
Oh,
He's
wow.
like, but I mean, his voice is beautiful. It's exactly like what you hear on his recordings, and so it was good to see him. Yeah, so it was good. But like I said, if my eyes is puffy, it's because I've been in worship. I was crying and crying and crying and crying. So
Now, speaking of Fred Hammond, I don't know if this is true, but I can kind of see it. Is Fred Hammond and Melanie Daniels related? I heard they were siblings, and
really,
that's what I heard. I don't know.
I don't know. You're gonna make me look. I
I
don't know.
mean, both of them can sing.
Yes, yes, and he it's just and I remember a friend of mine, she loved we used to battle. It was funny. I have two friends that I've always battled music with. Like, well, my one friend is gone, but we always liked the opposite of the people that was out at the time. So when Fred Hammond came out, I love John P. Key. He is my go-to for it all. And so we would always be battling. Like she'd play her Fred Hammond, I'll play my John P. We'd be having our own battle. And then my other friend, um, she liked I, well, I end up liking her too, but I was Mary J. Blige and she was Faith Evans. And like she would just play it and I would be like, but Mary, and she'd be like, no, but Faith, but Mary. So we was like, wow, it was crazy. Okay. Well, let's get this beautiful party started, shall we? Well, welcome everybody to the Saturday morning tea, where we discuss health information, news, education, certification tips, uh, uh, battles, artist battles, and the week, as well as entrepreneurship, and of course, the revenue cycle at large. As you come in, don't forget to hit the thumbs up or like button. Or put your teacups in. You can put your teacups in as well. I'm Clarice Warner, the girl with the pearls, the founder and senior education director of the Professional Reimbursement Network, LLC, where coding education is key. And PRN is a healthcare compliance consultancy located in Cincinnati, Ohio, that specializes in revenue cycle and regulatory compliance in education. Now, let me ask you, do you know what it takes to be a certified marketable medical coder? Do you? Do you really? Well, before I introduce my co host, even though we have been talking for about 5 minutes, let me share with you information on a free free, yes, free email course on the 5 steps to become a certified marketable medical coder. Are you interested in medical coding, but not sure where to start and scared of wasting time and resources? Let me help you with the right steps to become a certified marketable medical coder. Learn more at bit.ly/5stepscoder. If you are interested in getting more information about the 5 steps to become a certified marketable medical coder, we'll check out the video description for the link. Joining me today, yes, is my partner in success, my co-host, Mr. Jesse, the registered trademark. Put some respect. Let me say that again. Put some respect on his name, the coding nurse. Sir, introduce yourself and tell the folks all about you.
Good morning, everybody. My name is Jesse. I live in Philadelphia. I have been in healthcare for a very, very long time. I left the bedside in 2014 and started in HIM. And in 2020, I created a company called the Coding Nurse LLC, where I help nurses and other people in healthcare with a clinical background transition into the wonderful world of HIM.
And how is that going for you?
It's going pretty well, going pretty good.
Yes,
And I have a
beautiful.
little story
Church
about
announcement?
no,
Okay.
about the trademarks. I'm having my website updated. So I had a meeting yesterday. So the guy was showing me the little mock-ups. I said, when you see the coders, can you put the registered trademark symbol after it, please? I said, I paid a lot of money for that.
Put some respect on his name. See, you should have just had it in. Could you put some respect on my name? See, I love it. I love it. All right, let's see who is in the house today. Good morning, Renita. Good morning. Good morning to our on the street correspondent, the crafty coder. Good morning, Tiana. Good morning, good morning, good morning. Good morning, Molly. Yes, yes. Good morning, Vicky. Hey, hey. We got a full packed house in here, huh? She wants to know, can you share your website?
I'm getting ready to right
Okay.
now.
All right, all right. I think we can pull it up. Yeah, there's his website. The Coding Nurse. Put some respect on his name.com. Yes, yes. All right, all right. So before we jump in, let me remind you that you can join in and add to the conversation. Don't be shy. Don't be shy at all. Your opinion. Oh, good morning, Carolyn. Good morning. Is
Good
that a
morning.
sunflower I see?
Yep.
You see my sunflowers back there? um, don't be shy. Your opinion matters and is always welcomed here. So just use the chat to put your comments in. And if you have a question for us, we would just ask that you put a Q first so we know it's an actual question for us and we don't miss it. All right, all right. So for those of you who are just joining us or watching the replay, today we are talking about the American Hospital Association, the AHA coding clinic, third quarter. It was a typo in the article that I referenced. It's the third quarter. So some key updates, some things that I thought were quite interesting. Like, really? We got to do that? Well, why? But anyway, we'll talk about it. We'll dive into that. But first, but first, but first, it's our church announcements. Yes, 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 yes. Sometimes you gotta. Yeah, yeah, yeah. I saw you. You was pulling back. You was ready to go. I saw you. It's like
Yeah.
the spirit was ready just to lead you and just put the fan up. Yes, yes. So take me back. Yes. Nothing about like that church organ. Nothing like that church organ. Mm, mm, mm. All right, all right. So our church announcement this week. Let's see. So one of the reasons why I said my week is so is because we lost some giants this week. We lost some giants. So starting off with James Earl Jones, who will always, well, he was Darth Vader, but for me, affectionately always will be Mufasa. He's just the Lion King was everything to me in my household, and I loved his voice in that movie. But then somebody took me back to oh, what was the movie with somebody took me back to one of the 70s movies. I'm thinking Pauline, but I know that's not the name of it. Oh, what was the name of the movie? Somebody had a little clip, and I was like, that was him with the lady. Um, he met her. She had some kids. I want to say she was a nurse.
Julia.
Julia. Okay, so I'm like, okay. And so he, was dating her or whatever. I said,
Mm.
oh, so they
This is
they took
Diane
me back to
Carroll.
that. Yes, I couldn't think of her name either. Diane Carroll. Yes. So yeah, so we lost that. But then my heart just broke with Frankie Beverly. So y'all know I love music, all kinds of music, and I can think of all kinds of things that has happened during the time with Frankie Beverly music playing in the soundtrack of my life. So in his honor, I got on my whites. I just uh, I've been there in all of my line dance classes. I was like, okay, we're not gonna do our warm up song to death. We're doing it to a Frankie Beverly song. I've been playing Frankie Beverly ever since I heard. So um, but I know he had been sick. He had cancer a few years back. I don't know if he had been in remission or if it came back. I don't know any of the details, but hopefully, he's not in pain or anything or suffering anymore. But it's just sad to know we lost him. He was just a cool, just laid back, cool dude. Like what? And he changed at least here. So we have an annual. It was called the Cool Jazz Fest years ago when I was a child. And has morphed to, I think it's now the Cincinnati Music Festival. So we have it every year here in Cincinnati. We bring all artists. But Saturday night is White Night. Even if Frankie Beverly don't show, he used to come. He used to be a staple. He was always here. But even if he doesn't come, it was a tradition that everybody came in all white, and it was just a beautiful sight to see. And we still do that to this day. People and folks who will travel and come, they know what to do. Everybody knows the assignment they have on their all white, and yeah. So I think I saw something around these here internet streets that they're gonna do a tribute all white something. I think next week. So
Oh,
yeah,
okay.
yeah. So that was part of my church announcements. The other thing, which is probably more related to this podcast, the 2-day coordination and maintenance committee meetings were held this week. Did anybody attend?
I was just going to ask her that. Does that mean we can watch the replay and get some CEUs?
You can. You can. So it's usually 2 day. Well, I don't think you get a full complement of because my understanding, and I didn't watch it, but the procedure piece was light. They said it was real light. Like it was only, and it cut off probably. I think it was predicted to stop around noon.
Oh,
Um, but 'cause normally they're 2 full days, but I'm sure the ICD-10 was a whole full day because they had several things that they wanted to discuss. So you can go out for the PCS portion. You can go to the CMS website and look up under Medicare coding and billing. Here, let me see if I can put this in the chat. That makes it easier, doesn't it? I'll put both of them. But you got to go two different places to do two different things. How about that? So for PCS, you go out to the CMS website, and for the ICD-10 materials, you go to the CDC, and you can get the information, the materials, the I don't know if the recordings are, they may be up now, but I know the materials are definitely out if you want to peep that. But they will eventually post the recordings if they are not there. Yeah. All things, all things. Any announcements on your end, Mr. Jesse?
I don't have any.
Okay.
Well, not at this time.
Not at this time. All right. Are there any audience comments? Let's see. No, I don't see anything. All right. Well, let's let the tea spilling begin, shall we? Let me get rid of this. Okay. So again, welcome to the Saturday Morning Tea. And today we're discussing the AHA Coding Clinic Q3 key updates for health information pros. I ran into this article from Dr. Erica Reamer, who will tell anybody she's a coder. She was sitting across the table from me like, I'm a coder. I said, well, okay. Your title says Dr. Da 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 da. She's like, I'm a coder. And then they'll call me doctor either. I'll be like, oh, okay. I'm just call me Erica. I said, okay, Erica. Well,
All right.
it was nice to meet you. No, I've met her a couple times. But anyway, so she talked about some of the things that she picked out a few items that were noteworthy in her opinion about the coding clinic. And remember, the coding clinic is one of our guidances that we use for primarily for clarification. So usually if there's something that folks are not clear about as it relates to how to code things, people submit questions, and they are then vetted by the powers that be over at the AHA. And oftentimes the information is then published in the coding clinic. The coding clinic comes out quarterly with a lot of good information. If and I thought they said they were going to do this, but I'm not sure. If we go back to having the certification in order to do your CEUs, remember if you have a coding credential, you used to have to go and provide the little test thing. I'm
Mhm.
not, I'm sleepy. I'm drawing a blank. Anyway, a lot, a lot of the information came from coding clinics. So if you were unaware, that was, you need to just pull out your coding clinics for the time period, and you could easily reference a lot of the material. It both the coding clinic and for the CPT portion, you can look at the CPT assistant, as well as any new guidance that was in your CPT book. So if they do bring those back, just FYI, that's where you can get your information. So one of the things that I thought was, well, a couple things that I thought was interesting. And if you, well, I guess if you don't code neoplasms, then you may not know this, but she talked a little bit about the guidance that was provided regarding a specific type of neoplasm. It was a non-invasive follicular thyroid neoplasm with papillary-like nuclear features, and it even has an acronym. It's NIFTP. And if you again know that when you're coding for neoplasms, you in the index you have they have their separate little area. You have columns that tell you the different types of of neoplasms. We're quite familiar with, um, your primary, so your primary or malignant primary or secondary, cancer in situ, benign, uncertain, and unspecified behavior. Um, Sometimes things fit squarely into the right column, and then sometimes, there may be some questions on, what is what. Again, you have to rely on the documentation that has been provided to you. The pathologist normally will have some sort of information regarding what that is, again, backed up and documented by the physician. Remember, um, you may not always find the right one, and so when you're looking, and if it doesn't really say, okay, right off, this is malignant, this is benign, you might get some it's pre-malignant, or it has the potential for transformation, which I was like, really, y'all would write all of that down but can't specify some other stuff. It's like, wow. Wow. Um, so then you would need to kind of look at the uncertain behavior column. And so for this particular uh, neoplasm, the advice given was that it should be coded under the uncertain behavior um, setting, according to the coding clinic. And Mr. Jesse, feel free to jump in at any time. The other one was, and I thought this was weird too, because I mean, well, because you don't go to the doctor for your birthmark, right? But
Right.
so Mongolian spots are typically AKA birthmarks. But sometimes they are a feature in some congenital defects, and they may actually, in their words, coexist with congenital defects. So, and specifically if these inherited disorders of metabolism or vascular birthmark. So, not just, I guess, your regular run of the mill birthmark, but then if there's other things that are happening in conjunction. So, you actually would need to capture them in those cases. And you would capture them with code Q82.5, congenital non-neoplastic nevus. Again, it could have some implication for future healthcare needs if something goes awry, or there's some additional manifestations related to these conditional congenital conditions. So yeah, you're supposed
What
to pick those up.
when I read that particular paragraph, I'm like, that must be for. I mean, I can't see an adult going all those years and they not. So it seemed like that was for like somebody very young, like newborn to like maybe toddlerish. Because those, I mean, because a congenital defect is usually, I don't know. I mean, because there are adults who do have congenital defects. I've coded
Right.
it,
But don't
but
they normally pop up earlier in life? They're not
you would
they're
think,
not diagnosed
well, especially something like
typically.
this,
Yeah.
because
Yeah.
the I mean, I'm a little iffy because when I used to do a lot of bariatric surgeries, they would do a surgical repair, and they would say that well, a diaphragm repair, and they
Mhm.
would say that the person had a congenital diaphragmatic hernia, and I'm like, well, is somebody really 42 and they had a hernia for all that time? I don't
Right.
know. I'm not a doctor, but that's what they say. So
Mhm. Hey, Demetrius, where you
yeah,
been? What's up? What's up? Welcome. Yeah. So, the other thing is spontaneous intracranial hypotension. Intracranial hypotension. I'm butchering words, aren't I? It says if it's due to a cerebral spinal fluid fistula, then you're looking at uh, codes G96.811 and G96.08. But if you only use those if it's for non-iatrogenic cases. So if it's from a post-procedural dural tear, then yeah, that's something totally different. You don't use that. But
Yeah,
it's
then it's a
only
complication.
it's a complication and you wouldn't use that. So you just have to make sure you're following. Oh, and for the people in the back, the non-iatrogenic cases are spontaneous cases. So that was the guidance related to that. Mr. Jesse, did you have anything to okay. And then let's see, what was the other? Oh, device placement during surgery. So if a device is placed but removed before the procedure ends, um, you don't code for the device.
Right.
So this came up with ureteral stent placement during abdominal surgery. So you don't be adding stuff and be like, "Well, we used it." Well, yeah, you used it, but it was just during surgery. It was. You don't code for the lights in the surgery either, do you? No kidding.
You know, when I got to that one, I'm like, people have we have got to get back to basics because that is when you're learning PCS, a device is clearly it states it a gazillion times. You
Hmm.
code a device if it is left in
That's
after the
right.
surgery is completed.
That's right. That's right.
I don't get it.
But they trying to. Well, I think it's they want to nickel and dime everything. And I used it. I opened up that pack and whatever. How can we make? But it's part of what you're. It's part of the surgery. So, mm-mm. No, ma'am. No, ma'am. No, sir. Let's see. Let's see. Um, there was a question about coding for abortions. So, when you're dealing with the buccal administration of an abortive patient to induce labor for termination, you're looking at 10A07ZX. Um, but remember, you're coding the procedure, not the administration of the medication. And so I think uh, I think there was some question about adding um, this, and it's actually in the um, code title. So why would you? I don't know, but this was something that came up as well.
I mean,
So
and it makes go
go
ahead.
ahead.
And it makes sense because the whole thing about PCS is always what's the intent of the procedure.
Mm-hmm.
So
Mm-hmm. Yep. And then we have our friend diabetes. And there were several questions about uh, diabetes without complications, and also a condition that invokes the quote with convention. So this one really is for providers. So if you're listening, this one is for you. When you document diabetes without complication, but also list a condition that triggers the with convention, you're setting us, the coders, up for a query. They go ask, make it plain, put it together. It's like you can save everybody some time and specify if that condition is unrelated to the diabetes or is it due to something else. And then, we can also, I think her advice was to give them a list of conditions that automatically result in the diabetes with a code. Um, and explain that they need to state that the second condition is unrelated to the diabetes, or that the other condition is due to something else. So again, education with the providers is helpful here. Otherwise, you'll be having these conversations and querying over and over and over again on these situations. Go ahead.
I do agree that education is important, but I don't know about giving them a list.
That
I'm
seems like leading to me. I don't like it.
exactly.
I don't like it.
All, all
Again,
you
this
have
is her opinion. I don't like it.
just say what it is you mean. That's all.
Mhm.
Because
Mean what you say.
right. Because I personally don't believe that because where I used to work previously, if anybody had diabetes and they had cellulitis, we always had to query. I mean, always if
Mhm.
the diabetes, if the cellulitis was due to the diabetes.
Mhm.
Now, cellulitis is not an automatic link. It has to be it has to be stated as a related to the diabetes.
Mhm.
So to me, if it's not, if the provider doesn't document it, what are we querying for? Like it doesn't. That's not an automatic thing. So if they would link it, then you know that you have to code it separately. And usually, most of it, but honestly, most of the time, they would end up saying that it was related. Very few times would they say it wasn't, and it did happen, but it wasn't the majority. So, but I still am like, I was a little, I didn't like it, but that's what they wanted to do. And I mean, it didn't really, it was no, as honestly as no skin off my nose. And actually, it's a lower DRG
Mm.
diabetes because I think it's that's E11. If it's type 2, it's E11.628.
Mhm. Mhm. Yeah. Yeah. I was like, the spidey senses. I was like, to leave them a list. That's part of the problem now. We have a lot of coders that just got these lists going around circulating. Oh, I can code da 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 da. Here's my list. Where's your book? Where are your guidances? Now we want to give lists to the providers. Okay, okay, all right.
Look, their book is in the same place. They don't know that a device is not, you don't code it if it's not left in
Right.
it. Because that's all throughout the book. It's
That's all.
everywhere.
Oh goodness. Well, I'm glad that somebody, I guess, but I'm sure they probably had something similar to this before in coding clinic. But I guess folks got to be reminded. Sometimes you got to revisit some things and let folks know. Absolutely. He said set people up
Uh-huh.
for failure. Absolutely. Because boy, they hold on to them lists forever. Them pages be crumpled, wrinkled, dog eared, tattered, all of the things, but they holding on to it.
Oh, now Tiana says she's for the list.
Oh Lord Jesus. Bless your heart.
Exactly. No, ma'am, Tiana. No.
No.
'Cause, the thing is, I mean, I've been in healthcare for a long time, and I just do not. I've never been one of those um, nurses that really overstepped. Because I think that a lot of nurses overstep their boundaries with doctors, and they think they're friends, and they think that they can help them. But when things go left, you don't have any friends,
Amen. Because everybody like
and they will in a minute. Oh, well, that's what they told me to do.
that's what they told me to do.
You, man, I don't play.
No, no. Oh
Because you
Lord.
can't. You can't.
She had more. I have a few lists on my desk.
Now, if you have a list of like your most frequently coded conditions, that I can see that because I've done that too. So you don't have to constantly look it up. But that's as far as my list goes.
Mhm. And then, just a list that's just been passed down. It's never, or do you update it? Are you making sure that, there are no changes to the code, the guidance, any of those types of things? Oftentimes they don't do that. That's not part of the list.
Well, let me. Speaking of lists, when I this is when I was working on the floor, I had a I worked somewhere. I had a whole bunch of IVs. I mean, people were getting because I worked in a like a subacute place, so a
Mhm.
lot of people came. And this was in Baltimore, so a lot of people have they have a very bad IV drug problem there. So a lot of people came for long term antibiotics, and they were getting like two antibiotics, one Q8, one Q12. So I had a whole bunch of IVs. So I typed up a list for my patients for the weekend. So when I was leaving on Monday, I was giving a report, and the nurse on my list, she said, "Oh my God, that's so nice. Would you mind? Would you give it to me?" I'm like, "Sure." Why did I come back a few days later? They were still using the same list, but some people's medicine had been it expired.
Right.
The order, I'm like, "What are you doing?"
Oh Lord. Yes, yes, yes. Yeah. He said once you keep referencing the tabular index, you start remembering verbatim. You do, again, if it's, especially if it's something that you code on a regular basis. I had a list, but I'd still reference guidelines if I didn't recall.
Well, see, look, Demetrius, you old school because
Exactly. Some
these
people don't even know tabular and the or index exists.
newfangled people, if they can't put it in a search menu, they lost.
Oh goodness. Yes, yes. Crazy, crazy. And then let me see, what was the last thing? Um, oh, the Canada. He said, Lord. When you call on the Lord. um, uh, Candida fungemia, am I saying that right? Is not the same as Candida sepsis. There's a two different conditions that require different codes. So they wanted to remind folks not to fall into the trap of using B37.7 for organ dysfunction. Disseminated or systemic Candida is what gets the B37.7 code. Um, yeah, so be mindful of that when if you're coding.
Wait
Uh-huh.
a minute. Why would you even think that you could use a B code for any kind of sepsis and an organ dysfunction?
Mhm.
Okay.
But again, either, and I'm not certain because I haven't gone to the and then you can always check these coding clinics if you have access for yourself. I don't know if this was a question, or sometimes coding clinic will have their own like article, so they're, I guess, hear a lot of information or want to make some blanket clarifications, and so sometimes they're like just articles that talk about um certain points of clarification. They give the history, they give all of the things. So I don't know if this was an article or if this was a question that popped up, but yeah.
I mean, because I'm not even this must have been just an article because it still doesn't give. I would have thought it would have been better to give the code for Candida sepsis
Hmm.
because this A41.9 is it's just it's like, but unless Candida sepsis has a specific code, it would be A4189 for
Hmm.
specified NEC.
Hmm. Yeah. Yeah. So let's kind of ask you all what how are you handling these things? So if you have a pre-malignant tumor coding in your facility, if you're coding that, how are you handling that? How are you coding those in your facilities or? provider offices. You can, of course, put that in the chat if you like. Also, what strategies are you using to educate providers on proper documentation other than sending your queries? Hopefully, you're not putting together a whole list and handing them over to them. Code this, code this, code this, or document this, document this, document this. Also, have you run into challenges with the with convention in diabetes coding? And last question, how do you stay up to date with the latest coding clinic guidelines? Feel free to jump right in and answer any of those questions in the chat.
Well, while people are mulling over their responses for the type of book, I have just never understood why provider education is so hard. I really do. And it's not all the provider's fault either,
Mm-mm.
because some people do not train correctly. Like they don't give them the right information, because it's so easy to hand the provider a list of codes and say this is what you use, but you don't realize what you're setting yourself up for
You're hurting them.
when you do exactly,
You're hurting them.
because then they they get in their bag, because then they think like Dr. Rima that they're a coder, and they're not. That's not your job. You're just supposed to specify a diagnosis, and if there's any kind of combination or any kind of associated, anything along with that, that's what you document. That's all.
Document.
And leave the codes to us.
It's the documentation.
Because
That's where the education needs to happen, is within the documentation and making sure um, you know, they understand how their documentation impacts everything else going after it, the downstream effect of their documentation or lack thereof.
like when I was doing outpatient CDI, like I had to create education material, and I had to create it, but I couldn't present it. How about that? But anyway, um,
How about that?
so when I was sharing it with my manager at the time, she liked it, and truth be told, like she later said that that's why she had hired me, because she didn't have the clinical background. And now you don't need a clinical background to educate somebody on diabetes and chronic kidney disease as a
Mhm.
coder.
As a coder, you educate them on the
You,
the guidelines, the information that's
exactly.
provided to you.
Where
This
you
is
don't
what you
have to,
need to do. You ain't trying to help them diagnose it or
exactly.
assess it. So
You don't have to document. You don't have to tell them, oh, well, check the three most recent EGFRs before you diagnose. No, that's
that's
a
not
whole
your
separate.
lane. That's not your lane.
Exactly. So when I got the information together, I just gave code categories. Like, for example, like when you have someone who has heart failure or heart disease and hypertension, and I gave some, clinical indicators, and then I put code categories.
Mhm.
She had gone on and changed and put in specific codes. But for this is what you do for this. I'm like, no. So she was like, well, you did it. I said, no, I did not. I said, a code category is not a code.
Mm,
That's why they call them code categories.
right, right.
Because these doctors, they're not going to go down by themselves. Trust me.
Absolutely not. That's how. So when we tell you, even from the enforcement perspective, because ultimately the provider has the final say. Ultimately, the provider of record is responsible for any of those claims that are going out the door. But they can say, I entrusted Acme Billing Company for all of my
Mhm.
claims and my information, and or revenue cycle company or whatever it is, who, especially if they're taking over the entire revenue cycle for a particular provider, then automatically that that attention shifts over here to them. Well, okay, well, what kind of information, what are your policies? What is the guidance that you are using in order? Because this is wrong. This is contrary to what our policies are. And we've paid you a lot of money based on some not right information. So, yeah, that's how you see those billers, or you see those revenue cycle companies, or you see other entities also being a party to that, because they doing their own set of interpretation. And doctor like, look, I did my part. I just documented it, send it over.
Exactly.
But they do have an obligation to, it's you should know or should have known. So you should know what's happening over here in your shop as well at some point. Somebody should. So yeah. All
It's a
of the
lot going
things.
on.
All of the things.
But
I tell these folks all the time, health information is not for the faint at heart. It's a lot. It's we've talked about this several times. It's lifelong learning. There's always something to learn. There's things that are always changing. So we have to make sure that we're staying abreast, especially, this is like Christmas time right now. So we about to get all these new books or new updates to our software. If you don't have a book, you still have an obligation to make sure that you understand what those things are. People will begin to have conversations. Here are the new codes. If you're, here are the areas where there are new codes. If you're coding in that particular area, then you need to make sure you know what's the what. Have a conversation. Do it yourself. And then, maybe it's some information that needs to be shared with your team. Have a conversation so everybody is on the same page. Otherwise, y'all setting yourself up for failure. It's a mess. Don't do that.
exactly. And what doesn't get talked about enough are these AHEMA and AAPC codes of ethics.
Mm-hmm.
Because, see, people, you can say, oh, well, this is what they told me to do, but you affirmed that you were going to uphold this code of ethics.
Mm-hmm.
And there is no, that's why it just do the right thing and stand 10 toes down in the right thing.
Mm-hmm.
That's going to be your only saving grace, because when the deal goes down and when the axe falls, they're going to bring everybody along.
Mm-hmm.
And if you happen to make it out, trust me, somebody who didn't is going to grab you by your collar and pull you right back in.
It's like crabs in the barrel. You ain't going out. We all in this together. Come on back down here.
There you go.
You're like, no, but I was out. I was free. I saw the light. Mm-mm. No, come on back
As they
down.
used to say back in the day, they're going to grip you up.
Absolutely. Absolutely. Wow. So yeah, so just, some information on the latest coding clinic guidance. Again, hopefully you are, as we've stated, staying abreast. Again, we got new codes coming out October 1. Hopefully by now you've already done some work. This is not new. You're not hearing about this for the first time. And you're preparing, because again, October 1, everything changes. All the new stuff kicks in. So hopefully you have prepared yourself for what is coming down the pike, whether it's in ICD-10 CM or ICD-10 PCS. And for our CPT folks, we got a little time. Our stuff don't start till January. We got a little time. But the symposium is coming up. I think it's in November. I think it's in November. So the CPT, um, I think they do like a CDI thing too, symposium. It's part of there's a CDI component, part of the symposium every year, um, that the AMA puts on. So it's best to get in early bird, because when that early bird cut off, that price is astronomical. And it's virtual though. It's a virtual, but I love it. I go every year. It's a
Well,
lot of information.
speaking of CDI, no, our boy Glenn was busy this week.
Wendy, I saw that article about the programs. We need to debrief on that one in the meeting after the meeting. How about that?
He is hysterical to me. He really is.
He is. And if you ever meet him in person, it's probably 10 times the worse. Like for real, dude, come down. Come down. It's okay. Come on down. Come off the ledge. But I love him. We love him.
Absolutely.
He's just passionate. Extremely
That
like
he
we're
is.
passionate. He's very passionate about CDI. He's been in CDI for years and years and years and just wants I believe just want to make sure that things are running in the spirit in which it was supposed to run. And things are done in the spirit in which they're supposed to do.
And like if I could just be honest about 30 seconds.
Give me my 30 seconds. All right. Give
I just
us 30 seconds.
when I compare like having been in both areas,
Hmm.
I just think that there's so much bull crap in CDI. So much. And it's like these people have these long, they think they're having high mind or high level conversations, but everything comes down to the basics.
It does.
And what it comes down to the basics of is most people in CDI do not understand revenue for real, for real. Because revenue, as we all know from the Saturday morning tea, comes down to ICD 10 and CM, PCS, and in some cases, CPT. If you don't have a firm understanding of the codes and the code process and how it really, really affects documentation and reimbursement, what are you doing? But they have created an entire industry where they have divorced themselves from having to know it.
Mm.
So this is why you have all this convolution because y'all you sitting up here, you don't even know what you talking about, Mary Lou. For real, for real.
Wait, I should have grabbed my tea because I know it was real serious when we heard you tapping your hand on
Yeah.
the. Ah, and not Mary Lou though.
I mean, I have been in meetings and I'm like, what is she? I be wanting to be like the Sandman from the Apollo, just wanting to just go virtually just yank them, like set it, go turn off your screen.
Go in the weight room. Go in the weight
Yeah,
room. Be like, what happened? She just cut off in mid sentence. She
I'm
was
in a
talking crazy. She
twinkling.
had to go into the weight room. Go in
Yeah,
timeout. Go timeout.
yeah.
Yeah, you right. That part is just because I'm always an observer. People talk about me all the time, especially in meetings. Because I'll sit back like and just be shaking my head like they have no damn clue. Like somebody then gave them a little buzzword and they taking it and they running with it and they think, oh my God, I sound so intelligent and I sound so da da da. It'd be like,
And they be talking the talk too. Like
shit, like
they be hyping themselves up. All they need is a beat. That's all they need is a beat. Cause they
just be like, and I so and my facial, I'd be like, tone it down, because I'm looking like,
yes.
do y'all hear this? Am I the only one? I can't be the only one. I cannot.
When I'm so glad when I'm in meetings where I don't have to be on camera because it would
It's painful.
it is.
You're like, and I'm looking around like, did y'all hear? Is it just me? Is it just me?
And then what'll happen
Is
is
it just
then
me?
yes it is. It, because then they would then in their hypeness they get the other clueless people hyped and then
Hyped, and they think, oh, you're the knowledge, you're the expert, you're the shmee. Let me go to you because you obviously know what you're talking about. Da 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 da. So it's the damn blind leading the blind.
and then and in your mind you're sitting there like Give it about a good 3 weeks, and when it hits the fan, they're gonna be right back where they started, and that's exactly what happens.
Well, unfortunately, we thought that and that wasn't right. So we have to regroup and come up with a different strategy in regard to that. Like it can all be so simple. In my words, it can all be
Yeah,
so simple. Mm-mm-mm. I love it. I love it. That's funny.
I mean,
All right,
I
y'all.
just wish people could see it because
I
it's
know.
something to behold.
It is. It is. And I'm sure it is happening in these round tables all across the world, but specifically all across America.
Yes, but I have an example, but but it has to be for the meeting after the meeting because I can't.
Oh, there you go. There you go. There you go. That's our segue.
No, and that's why I'm talking about it. That's why I'm so animated because I just went through it.
Oh my God. Oh my. Oh, and I got one for you too. How about that?
Okay.
Oh, baby.
and
Oh. When I
that's
tell you it was a physician on fire, mm, like, excuse me? So I'm on a I'm in a I'm in a the Zoom meeting and we got all kinds of folks and dude, y'all not gonna stop him. Nobody's gonna stop him. That just gonna let him just keep talking this talk. Like I'm like, if if the fans was watching,
that to
coming down.
anybody, yeah, to anybody who was watching this either live or the replay, if you master, and I mean master, and master does not mean memorization.
Amen.
Master meaning means know how and when to access the information you need to access.
Absolutely.
If you master the coding guidelines for CM, PCS, and or CPT, whether you work inpatient or outpatient, you will be invaluable because there will always be people out there who don't, who should but don't.
And while you're mastering that and have that skill set and that level of knowledge, make sure you know your worth. So when you walk in there, you know your worth plus tax.
Part,
Don't let them play with you. Don't let them play with you. Not
that
at all.
part.
Not at all. Oh, this is great. I can't wait till the meeting after the meeting. But let me find my little slide because I know it's going down. So, are you thirsty for fresh perspectives on the healthcare revenue cycle?
I
Thirsty,
like that.
thirsty.
I like.
Show my tea. Woohoo.
Uh,
By becoming one of the tea sippers, you'll join a community of sharp minds who savor the complexities of the healthcare revenue cycle. So, why sip alone when you can seep in knowledge together? So, come, let's spill the tea on industry insights. So, what can you expect as a valued member of the Tea Sippers? Well, exclusive healthcare insights. You gain access to in depth articles, webinars, and resources covering the latest healthcare trends, compliance updates, and revenue cycle best practices. We got a whole archive full of information for you and entrepreneurial endeavors and information as well. Early access. Be the first to receive expert insights and guides, ensuring you stay ahead in the ever evolving healthcare industry. Hey, Shonda. Personalized support. Enjoy direct access to our team of experts for guidance on medical coding, compliance issues, and revenue cycle management. We're here to answer your questions and support your professional growth. And my favorite, the community connection. Join a private community of healthcare professionals where you can network, share experiences, and Lord, do we not share experiences and collaborate on finding solutions to common challenges. So, by supporting us, you're not only advancing your healthcare knowledge and career, but also contributing to the success of the Professional Reimbursement Network, LLC, was a resource that empowers healthcare professionals like you to thrive in their roles, goals, and dreams. So thank you in advance for considering becoming a member of the Tea Sippers. Check out the link in the description of the video, and you can also go to bit.ly/ the PRNT Sippers. Yes, that's bit.ly/ the PRNT Sippers. Your support means the world to us, and we look forward to helping you excel in the world of health information and healthcare revenue cycle.
All right.
Ta-da!
Now, Tiana has a. She said, "I sit for my exam Monday morning. Any advice? Which exam, Tiana?"
Yeah, that's important to know.
Yep. Oh,
Different
CPT.
strategies. Mm-hmm.
You first, Clarice.
Well, not so is Tiana, is she your person?
I think so. Has a little link because I have a little link.
Okay. Okay. Well, Tiana, um, as we've mentioned before, you make sure you understand and know your guidelines. Hopefully, because I mean you in the 11th hour right now. Hopefully you've practiced under time. That's very important because this is a timed exam and you want to make sure that you are not overthinking it and spending a lot of time on questions. Um, my unpopular opinion is because most people do it the opposite way, but I don't. I like the hard stuff first. I like to coast for the rest of my day. So those areas that I know I have challenges, that's where I'm going to first. Because and I know it's different with the electronic version of the test, but when I was a proctor, I felt like I was talking more and giving time more towards the end, which to me just increased anxiety. So I'm like, I need all that first half of the test to be focused on what it is I need to make sure I need the time to focus on. So hopefully you've had the opportunity to take those practice exams, take them under time. Make sure you read the question because sometimes and really understand what it is that you're asking. Because sometimes we'll glance at the question or think we read it and think we know what they want, but then we done missed a whole word or we done missed a whole thing. And just make sure you understand by reading the question what it is that they are actually asking you to do. I know a lot of people talk about elimination, and that is a whole thing because there's some things that makes absolutely no sense. um, but I'm not one unless it's something that I thoroughly don't have any clue about. Um, I'm not one to just be looking at the answers or the choices that they provide and trying to go back and look. No, I coded as it's a case presented to me. So when I took my exam, I coded them. Like, okay, well, okay, this is what we need to do. Let me go to the. I actually did a whole coding because that's what I was taught to do, and so that's why I was successful in my exam. Very, very successful. But again, that was a long time ago. Um, Let me think. What else, Mr. Jesse? What else am I missing?
Like for me, especially for like the outpatient exams, I just think that it is really important that you mark up your CPT book, like those families, and pay attention to those. Like you should like those parenthetical notes.
Yes. Oh my God, those are your friends. I call
Yeah,
them. I call them parenthetical guidelines. Because they are
yeah,
guidelines. They're guiding you, and unfortunately, you normally see them after the code. So most guidelines come before the information, but always eyeball and make sure there aren't any parenthetical phrase that will tell you, okay, don't code this with that, or make sure
yeah.
you include that. So make sure you eyeball them. But then in that same vein, know your book, know your manual, know where to go. I mean, you have folks that have and you can't, please don't write volumes and volumes and volumes in your book. You won't have time to find that. You won't have time to look for that. But Tabbing is great. Tab the areas, tab the sections, so you can go and quickly reference those areas. But all of that stuff that I be seeing people do, I'd be like, oh my God, what are they doing? You didn't wasted a whole, you can't get that hour and a half, 2 hours back. Don't do that. Don't do it at all.
And just know that overall, every coding exam you take is always an exam on your knowledge of the guidelines,
Absolutely.
not your knowledge of
Absolutely.
coding, because they assume that you know how to find it. But they want to
Exactly.
know, do you know how to apply it? Do you know that if somebody is treated strictly for dehydration and they have cancer, how do you code that? That's what they want to
Exactly.
know. They
It's
don't care
application.
about the right. They don't care about the code for dehydration. They want to know, do you know how to apply it?
That's right. Absolutely. Absolutely. All right, all right. It was something that I saw that I thought was really, really cute. Cute, cute, cute.
And good luck to you.
And good luck, and good luck. All right, all right. Well, this was a fun time had by all. I believe, I believe. If the tea was spilled, let me see your teacups. Let me see your teacups. Yes, yes, yes. Um, oh, this is what I want to say. I wanted to remind you that in the world of health information, knowledge is power and proper documentation is everything. I'm gonna be incorporating that somewhere in all of this. So, was the tea spilled today? Let me see. Let me see. I don't see a teacup. Let me see your teacups. All right. If this information was valuable for you, help us share this message with others by sharing the video and subscribing to the channel. Be sure to follow us for more information on all things health information, compliance, revenue cycle, and medical coding. And as you leave, don't forget to hit the thumbs up or like button. Also, check out the Coding Nurse channel on YouTube, and you can check out his website as it's in the comments. So, check out what's new and improved and fancy and all of the things over there at the
It's coming,
website.
but not yet. Yes.
All right, all right. So this has been a great session today. See you tea sippers at 10:15. Oh, there's one. There's one. Thank you, Renita. There's a teacup. See you at 10:15 a.m. Eastern Standard Time for our meeting after the meeting. Again, thank you for joining. And remember, be safe, be kind, and don't wish for it, work for it. Until next time, take care. Have a great weekend. Be
Bye
safe.
bye, everybody.
Don't do nothing we wouldn't do. No.
No.